Good morning, good afternoon, good evening, depending on where you are in the world. Welcome again to our webinar. This time we're very excited to be here today. I think one of the first things you might notice is our logo has changed. We do now have a new logo launching us into another 18 years of existence. We're very excited about our new logo launch. And we welcome you to join us on today's webinar. And to be able to get started, again, this is going to be based on the International Organization for Standardization, the ISO 15189 for medical laboratories. With me today is Dr. Julius Lutwama, who is the Deputy Director and Head of the Department of Virology and Emerging Infectious Diseases out of the Uganda Virus Research Institute. Julius, welcome.
Thank you very much. Good morning, good afternoon, good evening, everybody.
Well, thank you so much indeed for joining us. Just before I hand over to you, I'm going to take our listeners who are here with us today through some very basic concepts with regards to the standard ISO 15189. And this would be a perfect introduction for you to be able to jump in and do your presentation. So just to be able to start, there are 4 key elements that I want to visit today with regards to technical requirements, which will help us be able to appreciate, which would allow us to appreciate Dr. Lutwama's presentation. Those elements are personnel, laboratory equipment, and then laboratory agents and consumable results. The area of results is a very key part in this particular standard. There are actually 3 key clauses that refer to results, 12 sub-clauses that refer to, that deal with this. And then there is also information management, laboratory information management. That is actually very key in this. So looking at personnel, and I'm not going to go into the details of this because I want Dr. Lutwama to talk to us about how UVRI has been able to go around this and the successes they've had managing the COVID diagnostics. So looking at personnel, there's some key elements that we have to have when we're thinking about personnel. The very first one is personnel qualification. As we go into COVID-19 and we do COVID testing, some elements that really need to be looked at is the competencies of the personnel, their qualifications in terms of training, experience, and skill. There is the need for a job description as well. Personnel introduction to the organization's environment is key because every organization is different. And then the training that the personnel is going to need to work in a specific environment. Also, I mentioned competency. This personnel have to be assessed periodically. And when I say periodically, that could vary from one institution to another. But the standard requires that period to be within 12 months. A review of staff performance, it's key. Continuing education and professional development actually allows for the personnel to stay on top of developments that are going on in the field of laboratory diagnostics. And then last but not least, with regards to personnel, is personnel records. We need to keep records on all our personnel. It doesn't matter whether there are full-time employees, whether they're volunteers, whether they're students, or they're part-time employees. We need to have records on all personnel that come and do any kind of work in the laboratory. Looking at the next thing here, laboratory equipment. There is something as simple as equipment acceptance testing. We don't just buy equipment and then throw them into our labs and then we start using them. There is acceptance testing. Depending from one case to another, it might be validation or it might be verification, depending on which laboratory it is going into. Then there is equipment instructions for use, usually the equipment manual, the equipment guide, that tells you how to be able to use the equipment and what you should be looking out for. Equipment calibration and meteorological traceability. This is pretty important because it allows for us to be able to ensure the reliability of our test results. Then maintenance and repair. This is something that has to be actually a complete part of the laboratory's equipment schedule. Then there is equipment Incidents reporting is also very important, and equipment records. We need to be able to keep records, just like we keep records on personnel. We also do need to keep records on our equipment. This includes our daily maintenance. It includes service maintenance. It includes any repairs. There needs to be records kept on it. And I broke equipment down into two sections because this is most probably the largest part besides clause 5.4, which deals with sample reception. So I broke this down into two parts. So I look at laboratory equipment and then laboratory reagent and consumables separately. In laboratory reagents and consumable, there is the whole element of the reception and storage of the reagents and consumable. Specific temperature requirements, specific storage requirements. What is the acceptance testing for use with the different reagents? Then something as simple yet important, inventory management. In one of my presentations, I spoke about what is going on in the COVID world. We need to move from just-in-time management to just-in-case management. And when you go into just-in-case management, inventory management becomes a very critical part of managing your reagents and consumables. Then there is instructions for use. A lot of the reagents comes with inserts. Those inserts can be used very preliminary to use the reagents. But over a very short period, 90 days to 6 months is reasonable. We should be able to transfer those inserts into standard operating procedures to be used by the laboratory. Then there is adverse incident reporting. This is a situation where the reagent does not perform as it is supposed to perform. You're supposed to automatically do one of two things. You call your local drug administration, or you report to the manufacturer about differences in or adverse events that you're seeing using their reagents. And then again, there needs to be records that are kept as to what you get when you do reagents and consumable understandings. Then one of the other key elements and the very big element is results. As I said earlier on, the standard, the ISO 15189, actually talks about results 3 times. It's most probably the only element in the standard that is actually repeated this many times, with almost 12 sub-clauses attached to it. The first time it addresses results, it talks about ensuring the quality of examination results. And then it goes on to talking about reporting of results. And last but not least, it talks about the release of the results. So I'm just going to quickly look at ensuring quality of examination results. When we talk about ensuring quality of examination results and thinking about what is going on today with COVID testing, some important elements come to play. Quality control materials. As we do COVID testing, quality control materials is beginning to become very, very essential. The quality control data needs to be seen. The curves keep on changing. Different tests are looking at different endpoints. And that is very important to look at, to evaluate. Interlaboratory comparison. A lot of the test kits that are actually out today for use for COVID-19 testing are actually being used with emergency use authorization from the US FDA. So interlaboratory comparison is key, but it's not, you can also do that in lieu of doing the external quality assurance, but the preference would be to do external quality assurance. Alternative approaches to ensure your results is key. Then analysis of interlaboratory comparison of samples. This is very important because as we know, the virus is changing very, very frequently. And so analysis of interlaboratory comparison becomes really key in terms of us understanding what kinds of results are going to be released. Evaluation of laboratory performance, comparability of examination results, and finally, again, the personnel records that are associated with actually doing the testing. So as I mentioned, results actually has 3 clear clauses that deal with it. The other clause is reporting of the results. When you talk about reporting of results, you're talking about report attributes. You're also looking at report content. What is the attributes to the results? What are the contents that go with the result sheets? Or if you're sending out results electronically, what is the content of that electronic release of results? Then the last of the three elements is release of results. It looks at automated selection and reporting of results. This is a situation where the lab is pretty advanced, and this equipment that it uses is already programmed to be able to select what we would refer to as normal or biologically acceptable results. And those ones can go out without any further review. Then there are also revised results. The standard looks at results that have been revised, and it actually ensures that once results have been changed, there is actually a procedure on how that change is going to happen and how those results are going to be released. Then another very important element, because we are in the year 2020 and after COVID, one of the biggest things that is going to happen to us in the world is how we move into the digital space. And so laboratory information management is key. And I drop at the bottom there the standard for information security management, ISO 27001. So as different laboratories continue to release laboratory information into the cloud, whether it's for storage, there needs to be a thinking about ensuring that different labs get certified to ISO 27001, which basically looks at authorities and responsibilities for how people access results. In the area of information system management, which is one of the clauses associated with lab information management, there are some very key elements that must be looked into when we look at this area. There is the element of collection of the sample, the element of processing the sample, recording, reporting, storage, and retrieval. All of these elements collectively constitute the lab information management. If you have bits and pieces of this, then you actually do not actually totally qualify to say that you're running a lab information management system, as most people have come to know it. And there are two very important elements that come with the laboratory information management. First and foremost, your laboratory information management has to be validated by the supplier. Once that validation is passed, whichever laboratory is going to use the system actually has to ensure that they do a verification process before they can go on and implement the lab information management system. With these ideas, this background, looking at results, looking at lab information systems, I now want to invite Dr. Lutwama to join us at this point and talk to us about how UVRI got started with doing COVID-19 testing in Uganda, some of the exciting things that they've gone through. But please, if you would, Julius, just start off by giving us a little history on the Uganda Virus Research Institute, and then take us through how you've managed testing and diagnosis during this period. Welcome.
Thank you very much. Once again, good morning, ladies and gentlemen. Good afternoon and good evening. I believe you are joining us from different places. Uganda Virus Research Institute. Let me share the screen. Well, Uganda Virus Research Institute was initiated or was started in 1936 by the Rockefeller Foundation when they were trying to find the eastern extent of yellow fever disease on the African continent. And so they asked Uganda government at that time whether they could have a place where they could start off to do investigations on yellow fever in Eastern Africa. At that time, it was the East African Protectorate. Uganda was a protectorate just like Kenya and Tanzania. So Uganda was given the opportunity to do this work. So the Uganda Protectorate gave them what at that time was called the Trypanosomiasis Research Institute, which had started in 1931, but the disease had virtually got controlled. So our work started in 1936. Over that period of time, of course, Uganda Virus Research Institute has engaged in a lot of research work, particularly on viral diseases, but also including other diseases on the African continent in Eastern, Central, and Southern Africa. At the moment, to cut the story short, the Uganda Virus Research Institute functions as a public health related research institution, carrying out most of its research work on viral infections. It is a reference center and has specialized testing for virus diseases. Here at the Institute, we do training and carry out educational activities for both masters, PhDs, postdoctoral students, as well as education of the public, school children interested in sciences and things like that. We do a lot of disease prevention, control, and microbiology. We are involved in emergency preparedness. Our data, our information is used in regulation, policy development, and improvement of quality. We do a lot of expert advice activities, both to government, other scientists, universities, and we have quite a number of enabling partnerships here at the Institute. We have several programs. We have the Medical Research Council, London School of Hygiene and Tropical Medicine program. We have the CDC Uganda program. We have the International AIDS Vaccine Initiative program. We have the NIH Rakai Health Sciences program. We have Rockefeller, we have Wellcome Trust Foundation activity. So we have quite an enabling partnership activities here. Of course, we do a lot of communication and public engagements. So that is what our functions are. Turning only to the public health role, we have laboratories which support programs to prevent and control communicable diseases. And we also play a key role in the epidemiological investigation of disease outbreaks. UVRI is very well known for its activities on influenza, Marburg, Ebola, Crimean Congo hemorrhagic fever, Rift Valley fever, yellow fever, and so on. So name all the viral infections in the country. Of course, not forgetting HIV, AIDS. There is a lot that is being carried out at the Institute. In addition, UVRI public health laboratories serve as local infectious diseases reference laboratories for clinical laboratories, but they also serve as regional and international reference laboratories. And of course, we conduct fundamental research. I am now going to turn to the Department of Arbovirology, Emerging and Re-emerging Infectious Diseases. This is the department that actually does a lot of public health activities at UVRI. And in this department, there are several programs. There is the Arbovirology Zoonotic Diseases Surveillance Program. And each of these programs has its own laboratory. The Arbovirus Zoonotic Diseases Surveillance Program has the WHO Eastern Africa Regional Yellow Fever Reference and Research Laboratory. We have the Plague Surveillance Program with the National Plague Diagnostic Laboratory, the Influenza Surveillance Program, which has got the National Influenza Center, and the WHO collaborating National Human Influenza Diagnostic Laboratory. And this is the laboratory where we are going to concentrate most of the activity, most of the presentation, because most of the activities on COVID are actually in this particular program. Of course, the other program are the VHFs and other emerging diseases. And this has the WHO EDPLN, Special Pathogens Diagnostic and Reference Laboratory. And this again serves also the eastern part of Africa. And we have the Foot and Mouth Diseases Studies Program, which has got the One Health Diseases Diagnostic Laboratory. At UVRI, in these laboratories, we have developed capacity to be able to diagnose about 40 viral diseases, and we can do hemagglutination and hemagglutination inhibition testing, ELISAs for IgM and IgG and antigen ELISAs, and other enzyme immunoassays. We can do immunofluorescence assays, we can do PCR molecular testing, both conventional and RT-PCR. We do virus isolations, molecular sequencing capabilities for NGS sequencing and metagenomics, and of course, flow cytometry and other chemistries. Now turning to COVID. So after giving you an idea of what we have in this department, let me give you an idea of how we have moved with COVID in Uganda. We initiated our investigations way back in January when there was a lady who actually came from Wuhan. This lady came and after staying for a few days, went and visited the surgery clinic in Kampala, and she had flu-like symptoms with a high fever, of course, flu and a cough. So we were invited to go and pick a sample from this lady and see what we could do and see if this lady apparently, whether she had COVID. Over a period of days, because we were invited for different investigations in Masindi, Hoima, and several other places, especially where we had Chinese nationals, because these Chinese nationals kept on coming into the country. And of course, some of these also developed either fever or cough or flu-like symptoms. And the population was uneasy. And in fact, in some places, they almost attacked them. And we were being invited to go and pick samples from these people. Of course, at that time, we didn't have the kits. All we were doing is to test these people using the influenza kits, which we had to see if these people had influenza and not really to see whether they had COVID. Good enough, all of these people, when we tested them, they were having influenza and not having COVID. Towards the end of February, we received a kit of 48 tests, and we repeated all the samples we had picked earlier. And of course, we found that they didn't have COVID. So that relieved us. And of course, we were more certain now that we didn't have COVID. On March 11th, 2020, the World Health Organization declared COVID an outbreak, a global pandemic. And of course, on the 21st of March 2020, a traveler was intercepted at the health screening point at Entebbe International Airport. And this was our primary case. So we had teams whom we had trained in Entebbe Hospital, and these teams were managing the screening point at Entebbe Airport. And of course, they suspected someone. And when a sample was picked and we tested this sample, it gave our first case of COVID. As we stand now, 6 November 2020, a total of 14,066 have been registered as positive with COVID out of 122 districts of the 136 districts of Uganda. Almost all districts have been affected. There are only 14 small districts which haven't been affected as yet, where no case has been identified as yet. And of course, the fatality rate is 9%. We have by the 6th, we had 131 deaths. As we speak now, we have about 14,000, more than 14,500 and 133 deaths. So a cumulative total of 567,713 laboratory samples had been tested. These are new cases which we have not tested before, but of course we do a lot of repeat testing, especially at the beginning, where we had to do almost 3 tests on each of the patients, because we had to do the initial test, then we had to do 2 other tests before any case was released, and the 2 final tests had to be positive. And in between, of course, we would do several other tests depending on depending on the presentation of the patient. And knowing that many patients, of course, had mild infection, you would test, but then, of course, they would still be positive. So you could do like 2 or 3 tests before the final 2 tests, which were negative. So probably we have done up to 700 plus tests for cases. Of course, the earlier strategy was the TIT2T, that is test, isolate, test, isolate, trace, quarantine, and test again. So the laboratory the laboratory was testing all suspected and confirmed, of course, cases. And mainly this was based or biased for travelers who were coming into the country, either through the airport or through the road transits along the border crossing points. That is where the initial bias was. And of course, all the contacts of these people were being identified and listed and followed up. And of course, they were being tested, like I said, up. And then all quarantined individuals were also being tested before release. So what were the successes? How did we manage and how did we go about succeeding in testing at UVRI? Well, at the beginning, UVRI had well-developed capacity for surveillance and diagnostics for many diseases, like I have already reiterated up there. And of course, there was the influenza program, which was in place. And this provided the backbone of these activities. We were, since a couple of years, making sure that all cases of influenza were being investigated. And we had a surveillance system for influenza-like cases. And all pneumonia cases in these hospitals where we have sentinel sites were being followed up, and we had information on the mortalities and morbidities due to influenza, which we had correlated, extrapolated for the whole country, so that we knew the burden of disease. So all of this information allowed us to be ready to initiate COVID testing activities. We were able to manage or to handle for the first 3 months without government assistance, because we had what it would take for us to be able to do the testing. We had the personnel, we had the equipment, we had the reagents, and of course, we had started receiving donations from Africa CDC, from WHO, from CDC, and other partners and well-wishers, Jack Ma Foundation, the Chinese government, and so on and so forth, who were providing reagents and supplies to us to enable us move forward. We were able to handle sample collection, do the tasting, and of course, present results. During this period, of course, there were not very many samples that were coming in every day, and we were able to handle this. We were part of the teams that were developing SOPs, we developed manuals, we developed testing algorithms and workflow to make sure that the work in the lab was flowing smoothly. We had already developed workforce, but as the work continued, we had to develop further our workforce requirements and plans, and making sure that we had surge capacity as the cases increased. We had to train, we had the responsibility of training other lab personnel for rolling out of testing to other areas. We have trained over 38 personnel from 16 laboratories. And of course, many of these laboratories have been rolled out. We had the responsibility of providing QA and QC panels for certification of these laboratories so that they may be able to do the testing. We have the responsibility of validating test kits that come into the country, and we have been doing this quite fairly well. Of course, at the beginning, it wasn't simple. At the beginning, it was very difficult. One of the reasons was that there were not very many positive cases, and yet we had to do some of these on positive cases. And some of these test kits, you had to do this at the bedside. So you had to have many cases and moving from one hospital to another until you have enough numbers. Of course, sequencing of the imported and circulating strains of the coronavirus, which we did, and we already have one initial publication and 3 or 4 other publications coming. So generally, those have been our successes. But of course, there are many more challenges than successes. Over time, we got overwhelmed by samples. Around May, June, more than our average capacity of up to 3,000 at the Institute. We had looked at our capacity and seen how many samples at the Institute we would be able to do. And we had given to government that we would be able to do up to 3,000 samples a day. So as we started, there were fewer samples. Of course, only the influenza laboratory was engaged. Then, of course, as the samples increased, we engaged the other laboratories. Like I showed to you, we have 5 laboratories in the department. So we went on engaging all of these other different laboratories. And of course, we even engaged 2 other laboratories out of the department when actually when the situation had become very, very difficult. Of course, at the peak of it, we were able to do as many as 3,700 samples in one day. And of course, this was not easy. This meant, of course, people getting tired. There was a week when we did almost 17,000 samples in 1 week. And of course, staff were tired. Of course, the second the second challenge was shortage of reagents and supplies. We exhausted what the program had in the beginning. And during that period, even up to now, there is a problem of logistics management, getting supplies in time, getting reagents in time. Even if you have the funds, it may take you a month plus before your order goes through, and another couple of weeks before you get what you requested for. So this has been a very big problem. And again, this is a problem because as you fail to get the right supplies and reagents in time, you have to keep on changing how you're doing the work, using whatever is provided, using whatever is available. So shortage of funds was one other challenge. Of course, we developed a costing framework together with the CDC. And of course, one of the challenges was remuneration of workers, fuel for transporting workers, and doing response activities, because in the beginning, we had to go out. We were the ones who were collecting the samples and bringing the samples to the institute and testing them out and giving out the results. So it was a lot of work. We had, there was lockdown, and only our vehicles were able, could be allowed to move out and collect samples and bring in staff, but there was a shortage on funding for fuel. Of course, as more samples came in, we ended up with the problem of storage of samples. First of all, some of these samples would take long to come to the institute. And of course, as they came into the institute, some of them had started getting spoiled, especially at the time when we didn't have a good supply of virus transport media. We would have samples coming in normal saline and all kinds of media that people had produced, so that we put the samples in. And for these, some of these, of course, the samples would get spoiled very quickly, such that by the time some of these samples would arrive in the lab, they've started getting spoiled. And if you don't have good storage, most of the samples would spoil immediately. So this was a very big problem. And of course, servicing of equipment. Some of our equipment were supposed to be serviced around March to May, but then we were using them. Some of the service providers were supposed to come out from out of the country. We have some servicing arrangements with people in Nairobi, servicing equipment, people servicing equipment from South Africa, and all of those couldn't come in. So all of that became a big problem. This slide here was actually intended to show how we were receiving the samples and testing the samples. As you would see, there were times when we were testing so many samples above 3,000, and also at least above 2,000 samples a day. So our average is about 1,200 samples every day. And of course, this has gone down fairly a bit, because more and more laboratories have been engaged and they are involved in testing. So at least the samples which are being tested at UVRI have tremendously reduced. These are, I told you, we developed our ways of how we would do the costing, what was required, and what were the inputs. So we said for the outputs to be fairly, to have very good outputs through these activities, then we had to develop these resources, we had to develop these inputs. I will not go into this very much, but as you can see, to have the optimal outputs, you have to do procurement of tests and kits and accessories. You have to have good human resources. You have to have the test kits and accessories available. And of course, other accessories include fuel for you to be able to bring in the human resources. So for each of these, as you go down, you can go through this and see how best you can do this. What I want to go to is actually this one, where we developed an human resource capacity to be able to do the different amounts of samples. Again, anybody can go through this and be able to understand this, because we had to do this to inform the ministry that as more and more samples coming, we need more and more people. And if people are going to work day and night, then again, these are the resources we need. This is what you need. This is what you need to put in place for you to be able to do good work as we move from one laboratory to another, so that the government would know what it requires to be done, even when you go to different laboratories. Of course, these are the supplies that were necessary. These are the logistics and supplies which are necessary for a 12 to 14 hour shift. But of course, you know, we have been doing 24-hour shifts. So we developed this to be able to plan ahead so that we are not caught unawares as we moved on. Going back to the challenges, one of the other challenges is the turnaround time. We had suggested to government that our turnaround time was 48 hours. Of course, they couldn't allow us to have a 48 hours turnaround time, but we said that was what was ideal. And we thought this is what we required, not to be put on a lot of pressure. However, we knew we would do, we could actually provide data within 6 hours of the samples coming to the institute. However, sometimes you would do a test and the test would fail, and you require to do it again. And because of that, that is why we are asking for 48 hours. One of the other problems we had was poor sample level. This was a very big problem, and of course, missing forms and missing samples. So sometimes we would receive the forms like this coming in, but then you don't receive the samples. The forms will be very well packed in an envelope, but you look for the box where these samples came in, and of course you couldn't be able to see it. For other cases, we would be able to get the samples, and there would be no forms. But of course, this would take a lot of time, trying to make sure that all the samples come in with all the forms. And of course, there were times when you receive samples poorly packed like this. So you had to go through all of these samples and see how you make sure that each sample goes with a form. So if you receive so many of them like this in a day, just putting a sample to a form, making sure that each sample is given a laboratory number, so that the form and the sample are given a laboratory number, this would take so many hours for our teams. So that is why one other reason why we were requesting for a longer turnaround time. Of course, over time, we tried to solve this problem. We tried to solve this problem, telling the people who are collecting the samples how to pack them, and packing them at least in Ziploc bags of not more than 10 per sample, instead of just dumping them in the cool box. Dumping them in the cool box like this was really a problem. Sometimes you could even receive some of these samples having leaked, or actually having some of these samples with the labeling already erased. Of course, there were several other, like I told you, there were so many challenges. Poor communication. We would have received people requesting for results, and sometimes you would have people virtually quarreling, people abusing you, requesting for results in a very bad way. And of course, you would tell these people that they are not supposed to receive the results from us. The results were supposed to be received from the Ministry of Health. But of course, many people could not understand this. They would tell you we sent you samples, we want results from you and not from the ministry. Other people, of course, even including patients or relative of patients, would request for results, and telling them that the results at the ministry was a very big problem. But also people in the ministry sometimes would ask for results, and telling them to hold on would be a very big problem. Poor communication from above. Decisions were being taken from above and sometimes not passed on to us below. Of course, many times we are not involved in these decisions. And if anything went wrong, they would tell you, this is what we had decided. This is not how we are doing it. This is what we told you, that you have to do things this way or that way. But of course, we tell them, we don't have that kind of information. So there was a problem in the flow of information to enable us to know some of the decisions that had been taken from above. Workforce anxiety. You know, first of all, the workers got tired. You know, they had worked for quite a number of months. And when we started shifts, of course, some of them are married, others are staying alone, and of course it is risky not being at home at night. People would come and steal their property. Of course, there was a very big delay before people were remunerated, and of course, when remunerations were made, we were told that a person cannot work for 24 hours, for 30 days, yet people were working for 30 days, working day and night. So there was a lot of anxiety, and people really, some people got frustrated that, of course, we had some people saying, I think we are not going to continue working. Of course, we continued talking to them and explaining to them. And of course, people continued to work. And of course, as the workload reduced, of course, we have people working in better conditions. And of course, there was the problem of people being taken for granted, that their employees, they just have to work according to what we have told them to do. And of course, this was not giving very good reflection from above, because it was like, yes, you have to do what we have told you to do, and you have to do it the way we have told you to do it. So this again brought a lot of misgivings to the workforce. Then there was conflict of interest. I've already said that UVRI is a public health reference laboratory and not a clinical laboratory. And of course, we were virtually doing work for a clinical laboratory. And of course, this brought a lot of misgivings, and that is why people were requesting for results immediately. Many of the clinicians, of course, they are more used to having results coming out just within a few minutes, within a few hours after a sample has been provided. But again, one other thing is that while we were involved in public health response, we had colleagues who were more interested in doing health research. So while we were waiting for samples to come so that we do testing on the samples were being taken elsewhere and first aliquoted, or sometimes the samples would actually disappear just because other people were interested in the samples for health research use and not really for public health response. Of course, there was a struggle for fame, a struggle for recognition. UVRI was well recognized. UVRI has the fame for responding. We had some of our colleagues who were more interested in getting fame and getting recognition. And many laboratories have come in, some of them have not come in really to assist in responding, but to be recognized as laboratories which can do this. Of course, another conflict of interest is business or personal gain other than public health response. We have laboratories which have come in and they're saying they're going to do this or that, but they are only doing this just because of money. We have also had people bringing in kits and requesting that kits be tested and pressurizing that we release the results even when the results have not fully been achieved, just because people want to do business. So that has been a very big challenge. Of course, let me give these concluding remarks. Uganda has been ranked by the medical journal, The Lancet, as one of the top 10 best performing countries in the world in suppressing COVID-19 as of August 2020. I also recall that at one time, Uganda was ranked as the third on the African continent for being able to do a lot of testing. This was also one of the achievements of partly what was being done at UVRI, and of course, the whole country. The country's ranking is a milestone shaped by Uganda's previous experience in combating emerging and re-emerging epidemics. Uganda's performance in controlling COVID-19 is rooted in her previous experience in combating other major outbreaks, such as the Gulu Ebola outbreak of 2000 and other VHF outbreaks. And of course, similarly, we prevented another big Ebola outbreak from the DRC since 2018 to 2020. We very well know that the outbreak in the DRC, which was very close to our border, just ended in June 2020, but yet another outbreak again started. I think it ended in August, and another outbreak started soon after. So for us, we need to keep this up despite COVID-19 having gone into the community. Now that COVID-19 has gone into the community, we need to do a lot, much more than our earlier successes if we are going to be able to continue succeeding. So thank you very much for your time listening to me. Thank you. Bye.
Thank you so much indeed, Julius. This was a phenomenal and very in-depth presentation. And thank you so much for what you've shared with us. As I listened to you go through the challenges, I was actually just thinking, I think this was 2005 or somewhere around there, when Hurricane Katrina hit Louisiana, New Orleans area, and I could think about as many challenges as you just mentioned happening here. So when we're dealing with public health emergencies, public health disasters, there are always going to be challenges that we have to rise up to and respond to. But I just want to go back very quickly, and if you don't mind, I'd like for you to share some other things with us. First and foremost, let me first of all give you my congratulations. UVRI has been around since 1936. That's a lot older than a lot of us who are around here doing business with you. So congratulations, I think that's phenomenal. But you did mention at the early phase of testing that you were doing 3 tests. While you were doing those 3 tests, was this an intent just to ensure the fact that you had the right positive results or the right negative results, or were you also trying to build some kind of testing algorithm for future use?
Well, we were trying to do 3 things. First of all, we had there is an echo. Okay, like I said, we try to 3 things. There is echoing. Sorry, we had more than one test, and we wanted to find out whether the other tests were doing as well as the WHO recommended Berlin test. So we are comparing these others such that we may be able to run these kits also. Then, of course, we wanted to make sure that we were getting the same results with all the others, and of course, getting the best algorithm. That is why we're doing these tests. Thank you, over.
I think that because the element of having a proper testing algorithm is very important. And as we go forward, and you spoke about the whole element of validation and having to do validation of test kits. We know at the very beginning of the pandemic, there was the very initial release of rapid diagnostic test kits, commonly known as RDTs in the field. And then all of a sudden they went down, and then now they're beginning to come up. As I mentioned at the beginning, a lot of the reagents and test kits we're using are all under the emergency use authorization. So there's still a lot of learning to go out there. But with regards to what you're doing in validation, do you have any information that you could share with the public with where we are in Uganda and the rapid diagnostic test kits coming into play, and how soon do you think they're going to be in use?
Thank you very much. Yes, we have done testing on a number of RDTs. Of course, one of the things is that all RDTs have got to first be tested again in the country to see how they are working. Then, of course, you have to test them on many samples compared to what the validation protocol goes through. And of course, the third thing is that while we are recommending a few of these to be used, the period of time when they should be used is very narrow. And that is why it has to be used by people who are very well versed with what they are doing, and only in either research based laboratories or in hospitals. And because of that, only a few of these have been so far recommended for Uganda. I recall we have worked on about 8 RDTs, but I think only 2 so far have been given a go-ahead for testing, initial testing, so that we test these on about 3,000 samples before we can give a final rollover to be tested by all other people. So I think we have Standard Chew and PanBio being now tested on a wider scale before we really give more people to be able to to do the testing using this. But the window for using them is very narrow, only up to 7 days after symptoms. So it is actually to be tested on people who are symptomatic, and only within a period of 7 days since the beginning of symptoms. Thank you, over.
Thank you. Thank you so much indeed for throwing some clarity on the use of the rapid diagnostic testing. We are just at the top of the hour, so I'm going to open now for people who are listening, who have some questions or comments. But Julius, there's one that was already sent on the chat from Dr. Eve. She says, could one say that the influenza test is accurate as the test for COVID-19, given that there were no false positives or false negatives in your pilot sample following the repeat testing after you had acquired COVID-19 test kits? This, I guess, refers to your earlier discussion when you mentioned collecting samples from the Chinese, and there are a couple of people in Masindi and thereabout, and then the repeat testing.
I believe the influenza test is accurate. We were only fortunate that we didn't get comorbidities between influenza and COVID. If there had been any case of influenza and COVID, of course, we would have missed it. We would have said that the cases we are seeing are influenza and not COVID, but I have not seen anywhere where they have had influenza and COVID. Of course, that was not the reason for us saying that they have influenza alone, but I know that the influenza test is okay. If we had had a case of, say, one of those cases having influenza-like symptoms, but then was negative for influenza, of course, we would have had a big problem. We would have imagined that probably that person has got COVID, and there was no way at that particular time for us to be able to test that person, except probably referring the sample at that time. Over, thank you.
There's an interesting question here, Julius. I say, why isn't Uganda manufacturing test kits? I know there has been some discussion in this area earlier on. I think Uganda, Senegal, South Africa were one of the earlier ones looking into this. But what's the answer? Why isn't Uganda manufacturing any test kits?
Well, of course, we have people in Makerere working with us in trying to develop some test kits. We haven't come to the point where we can say, yes, we have a kit that is ready for testing, but one is being developed. Then we also had one other test which was being developed by Professor Nantulia. This was also actually validated, and it didn't reach the mark, but it is being further developed to reach the mark. So while we haven't as yet got one that is being that is in supply, having been developed in Uganda, we hope that in the near future, probably we are going to come up with one. Thank you. Over.
Thank you so much indeed. We're going to go on. We're running a little bit behind. I just want to reiterate and bring together your presentation and some key areas in the standard. Looking at personnel, you did talk about personnel. You spoke about the human resource requirements. You spoke about the equipment. You spoke about servicing. You spoke about the challenges that are involved in servicing the equipment. You spoke about challenges with having consumables and reagents in the country. Some very key elements, but also there was also the challenge of results and how results were being disseminated, and the whole information management system around all of this. I just come back to this because these are very key elements in when we're talking about managing pandemic, managing disasters. These four elements, they might be out of the standard, but the laboratory standard, the ISO 15189, actually looks at these four elements very in detail to be able to help us support response to pandemic, response to the disasters in a public health environment, but also in diagnostic laboratory. So these are key elements on which everything that Dr. Lukwama has been talking to us is actually built on. And therefore, there is a strong need for us to be able to appreciate the standard as we continue to do diagnostic work in medical laboratories. I thank you once again, Julius. We look forward to doing this again. I know there are many questions that people would like to ask, so we really look forward to doing this again one more time. I hope you will be available.
Yes, I will. Thank you very much.
Thank you so much indeed. Again, we never like to end without continuing to remind people about staying safe. We need to check our temperatures, continue to wash our hands with soap and running water, keep the hand washing process for at least 20 seconds and more if you can. That is certainly very important. Use of sanitizers, if we cannot wash our hands, and absolutely please have some kind of face wear all the time. Please have some kind of a face wear all the time. The pandemic, the COVID-19 is a droplet. It's like influenza. So we want to be able to stop it from reaching our eyes, nose, or mouth. And again, in spite of the face wear, please continue to keep a physical distance that allows you for none of the droplets to fall on you or fall near you. Please, you can reach us again you can reach us direct call, you could see us on Facebook, or whichever way you choose. You could drive down and come to our Kololo offices, but we'll be very glad to carry on this discussion with you and look into ways we can support.